Okay, so the subject we're talking about today, vomiting, regurgitation, and diarrhea, which is obviously something clinically that's so relevant. We see due to so many reasons in so many patients. And I think it's really topical with the membership exams coming up because it's very examinable. There's a lot of kind of elements of it that I think are really important to understand about the mechanisms of what causes vomiting, differences in regurgitation versus vomiting, and things like that. So let's start with what's the difference between vomiting and regurgitation?
Abdominal effort.
Good. Yeah. Anything else?
Vomiting is stomach or intestinal origin. Regurgitation is
and
esophagus.
how clinically how would that look different? Like Matt's mentioned that they do abdominal effort, so there's often like a kind of before there's a vomit with the, sorry about the impression, with the vomiting as opposed to regurgitation. What does regurgitation look like?
Very passive.
Very passive, yeah. Often owners report they just put their head down and it falls out, basically. Well, what would they bring up? What's the difference? Is there any differences that we might sort of say, okay, well, it's more likely to be vomiting because of what they're producing?
Bile.
Would be won't be digested, and you can literally see the food with mucus sometimes, but that's it.
Yeah. There is a fair bit of grey zone there because a lot of the time dogs bring up undigested food when they're vomiting. And sometimes when they're regurgitating, they look like they've digested the food as well, because sometimes regurgitation can come from the stomach too. So there's a bit of grey zone, but it can give you an indication. Somebody said bile.
Yep. Bile.
Yeah,
like more acidic contents usually.
Yes, interesting. Yeah. So they actually looked at the pH of what they're bringing up as far as differentiating vomiting versus regurgitation. And there's too much overlap for it to be really accurate. Because a lot of dogs have gastroesophageal reflux and therefore their esophageal contents are quite acidic when they're regurgitating dogs. So the actual pH doesn't help us, but bile can. Bile's more likely to be associated with vomiting. It's not impossible with reflux if they're, with regurgitation if they're refluxing duodenal into stomach into esophagus, but it's a bit more of a stretch. Is there anything else?
What about response to therapy?
Good question. Yeah. Well, good point. Yeah. So what sort of therapy might you trial to differentiate regurgitating versus vomiting?
Antiemetics.
Good. Excellent. Yeah. So most dogs who are vomiting will respond to, I think, meropenem are most effective. Would anyone disagree with that? I agree. So I think meropenem usually stops vomiting unless they're obstructed. And if they're regurgitating, they should just keep going the same as they have been. What about time after eating?
There'd probably be considerable overlap with that too, wouldn't there?
A lot of grey zone, yeah. And what about other symptoms of like nausea, like what precedes the vomit or the event? Sorry?
Hypersalivation.
Yeah, exactly. So would we see hypersalivation with regurgitation?
No.
No. The presence of nausea is usually more kind of points you towards true vomiting rather than regurgitation. But there's so much overlap. What about a terminal retch or gag? Is that more likely to be a vomit or a regurg?
I would think vomit. Because regurg should just be very passive. So if there's a terminal gag, like the gag, isn't there then some involvement of the muscle somewhere?
It's a good
Wouldn't it be
point.
pharyngeal muscle like that becomes not autonomic, that it's a clearing mechanism from like post-regurgitant in the pharynx?
So that's actually what most of the time it is. So I think we've all seen dogs vomit and they go at the end. but vomiting tends to be more propulsive. So they tend to clear their larynx quite well in the process of it, as opposed to regurgitation, which is a bit more passive. And they've often got that mucoid stuff stuck in their pharynx. And that's what the gag at the end is. It's just them clearing their pharynx. So it can happen with either, but probably more common with regurgitation. And I think that's where, you sort of say to clients, is it passive or is it abdominal movement? There's quite a lot of abdominal movement associated with a terminal retch. So really getting down to the granular details with the owners, like, is the sound at the end of the vomit or at the beginning of the vomit? And all of that just can really help you differentiate.
And can you not also have like mixed, because if you're vomiting excessively, then you can cause like irritation in the esophagus, and then you actually have regurg as well. So like your vomiting starts, and then you also start regurging.
Absolutely. And a lot of the conditions that we see, for example, like anything that causes delayed gastric emptying, it's going to be a combination of quite passive, just kind of overflow regurgitation, as well as true vomiting. So you might have a pancreatitis causing a local ileus and this huge stomach full of fluid, and they might just be like regurgitating every time they move, but also having true vomiting associated with the irritation. So there's so much overlap between the two conditions, but it can help you, particularly in the chronic ones, I think, differentiate sort of how you're going to guide your diagnostics. If you can only do one test, you want to differentiate regurgitation from vomiting as best you can. You get a better picture of what's going on too. Let's start with kind of talking about regurgitation. What are the differences between dog and cat esophaguses? Esophagi?
Dogs, it's just striated all throughout, and in cats, the proximal is striated, and is it distal 1/3? That's smooth?
Mm-hmm.
Or was it the other way
Yeah.
around?
No, it's right. Exactly right. Yeah. So if you think about what muscles in the intestinal tract, it's smooth. And I sort of think there's this transition from striated up here to smooth somewhere along the course of the cat esophagus. Do cats regurgitate? Not really.
I think no. I think they
Not
cough.
really. Yeah.
Like
Yes,
that, when owners describe, it's
yeah.
actually a coughing, not a regurg.
Yeah, completely agree. So I've only ever seen one cat that gurged, and it had a gastroesophageal intersusception. Like it had its stomach in its esophagus. So it's probably what we'd sort of consider a hiatal hernia in a dog, but it was a unusual form of it because it had gone up inside the esophagus. And it was the most spectacular barium study I've ever seen. A very young cat, like with a congenital abnormality. But
Survived? Surgery?
yeah, it had a gastropexy just to stop its stomach from going up into its esophagus, and it did pretty well. It's a refluxy cat though. Yeah, so they like cats really don't gurge, and I'm not sure whether that's associated with the different musculature of their esophagus or the different diseases that they're likely to get. But we do see cats with like myasthenia gravis and stuff, and they don't really get that focal esophageal form of it.
Is there different vagal innervation sites for dogs and cats?
I actually don't know.
Is it different with how it innervates?
I don't know, actually. I've never
Like
looked at it.
Esophagus perspective.
It didn't mention it in the Edinger chapter, and I'm not sure whether anyone's really looked. And because I feel like they discover something new about vagal function every other week. So
yeah.
Maybe it's coming. So let's talk about the differentials for regurgitation or esophageal dysfunction, like broad categories of what might cause regurgitation.
Does pharyngeal, like dysphagia and cricopharyngeal achalasia and all that, does that count as regurgitation? Because in Nelson's they kind of group as regurgitation, and Ettinger's they don't really say.
Interesting. I would say that's gagging. If it comes from pre-upper esophageal sphincter, it's going to be a gag reflex or expectorant reflex, where they're just clearing the pharynx. Whereas if it goes past that upper esophageal sphincter and then comes back up again, then it's regurgitation. So that would kind of be my cutoff. But I haven't seen that clearly differentiated, but certainly in Edinger, they differentiate dysphagia gagging from regurgitation in their kind of.
So to be looking at like mechanical versus functional.
Good. Yeah, I think that's a really nice way of looking at it. So what sort of, give me some examples of a mechanical cause of esophageal dysfunction.
Obstruction.
Yeah, good.
And then like retro, or sorry, you go. Like intrathoracic tumor.
Good. So when you think of obstruction, I want you to think of intra and extra luminal obstructions. What's the most common intraluminal obstruction we see?
Foreign body.
Foreign body, exactly right. Yeah.
However, you can also have parasitism, that's a pyrocirca, whatever that is. The
Oh
granuloma.
yeah. Do we have that in Australia?
I have heard yes.
Oh,
I
Yes.
don't know. Somewhere in
Ooh.
the northern, yes. There's a
Oh.
podcast on it somewhere.
Interesting. Okay, that
What-
certainly hasn't been on my radar.
What about intramural, like abs, like puncture? I guess it's foreign body, but like puncture, like abscesses within the wall from stick injuries, etc.
Good.
Did you see that?
I've never seen, like, the esophageal mucosa is the toughest
Yeah.
mucosa you come across. So if you we sort of think about the gastric mucosa as really tough, and you do your scopes, and like the way that you do the scope is to go orally down the esophagus, through the stomach, into the intestine, and then you start biopsying, and you get these huge chunks of wall with your biopsy technique in your duodenum and proximal small intestine, and you come back into the stomach and you get these piecey little chunks of tissue, because it's so much, that mucosa is so much tougher than the small intestinal mucosa. Obviously, it's a more hostile environment, it has to be tougher. And then you go into the esophagus and you can't biopsy it.
Yeah.
It's so tough. So whilst we see abrasions of the esophagus, I think if it's not a force strong enough to cause full perforation, you're not going to get an abscess. Like that mucosa is so tightly on there that you're not really going to get like pockets underneath it.
Yeah.
Theoretically we could, but yeah, I've never seen it, and certainly I've seen quite a few perforations that have caused pylorus and pyomediastinum and stuff.
Yeah.
But never actually in the wall. Good. So intraluminal obstructions are almost always foreign bodies. Obviously, history is important here. If you've got a waxing and waning or kind of more chronic history, then mass lesions or abscessation or stricture formation would be other things to think about.
Where does hiatal hernia sit?
That's such a good question, actually.
Mm.
I guess
With mechanical.
it depends on what class of hiatal hernia it is, because it could be extraluminal or it could be intraluminal. You know what I mean? But mechanical.
How, like, what do you mean extraluminal? Like where?
There's there's 4 actual types of hiatal hernias.
Oh.
So one, like if you're doing a scope and you're looking at the lower esophageal sphincter, one, the stomach comes up inside the esophagus, it like prolapses almost. And actually, a lot of the time, what happens is it comes up through the hiatus adjacent to the lower esophageal sphincter and causes compression of it, rather than actually being inside.
More
So
like a tuberculum.
yeah, yeah, and it could like it. So if you've got the like muscular hiatus through the diaphragm, and all of a sudden, like, and that's just a little bit floppy, and the stomach kind of like, particularly in what breeds do we see hiatal hernias in most commonly?
Frenchies.
Brachy's, exactly. So I want you all to block your noses and close your mouth and try and breathe in and feel the vacuum that you feel in your. I want you to actually do it. Create that vacuum in your chest. That's how they're breathing all the time. And if you've got like a floppy little hiatus because you weren't very well bred and your stomach sitting alongside that, it's going to get sucked up in there, isn't it? When you feel the sort of degree of vacuum in there. And that's going to then compress your esophagus. So it's fine when you're not swallowing something, but when you've got a bolus of food, that's going to hit the bottom there and bounce back out again. So technically it could be intraluminal or extraluminal is the point. The long story. And what sort of mass lesions do we see in the esophagus?
Yeah, like leiomyosarcomas.
Good. Yeah. Is that going to be in a dog? We just talked about the type of muscle. What's the origin of a leiomyosarcoma?
No, it
Oh,
won't be because it's striated.
Thank you. Good. So generally sarcomas are the most common type. But in cats, it's going to be a leiomyosarcoma in the distal third. In dogs, it's going to be a different kind of sarcoma. Okay, what about functional? Oh, there's one more cool one. Say you've got a dog, 4-month-old dog, as soon as it started on solids, started regurgitating.
PRA.
Yeah, good. Yeah. So what's the classic? What's the not acronym? What's the full name of that?
Persistent right aortic arch.
Good. And what is persistent right aortic arch the only type of this congenital abnormality, or are there others?
I think there's another, but I don't know. Or remember.
I would just if you're doing an exam, write vascular ring anomalies, and they can't mark you wrong. So PRAA is by far the most common, but there's actually embryologically there's a lot of like arches that develop embryologically that then go away, and all of them can cause compression, or some of them can cause compression of the esophagus, so it's not always the persistent right aortic arch. Some of them also cause tracheal abnormalities, so it's something nice to just look at on an x-ray if you're kind of seeing a big dilated proximal esophagus and you see like a dip in the trachea as well. It's often not a PRAA.
I had a very interesting case like 2 weeks ago, and I feel horrible about it because I actually missed it. But I thought I could share it with you guys because a differential diagnosis would be a functional type of problem that affects the esophagus, I suppose. And would you like me to share it, Anna?
That'd be great. Yeah.
Okay, so oh God, I honestly feel so horrible about it, but I thought it was good for everyone to.
And if I reckon every mistake we make, the more people that learn from it, the better.
Exactly.
Yeah.
So on the 7th of April, I saw the Caboodle dog, 10 years of age. So he presented because 10 days. So can you guys see my screen?
Yeah.
From 10 days, he was not really interested in his regular diet, and he used to be superfood motivated. Diet, salmon kibble, and a mix of wet food, only interested in treats and human food, so was still eating food. The owner was feeding grain-free, was feeding tuna in spring water, and last weekend had a bile froth vomit, but in good spirits, like wagging the tail, keen to go for walks, no vomiting or diarrhea ever since, and was also chewing at the tail. So on the examination was super bright, eating treats, a body condition score 5.9. However, I did notice that since February, he had lost 500 grams. He didn't have a murmur. The chest was clear, no effort, pink gums, lymph nodes normal, soft abdomen, cervical palpation normal, no spinal pain, normal temperature, mild erythema around the perineal area, but everything else was normal. So I said to the owner, because of the age, it was like, let's take bloods. So I take him to the back to take bloods and to check for, I guess they wanted to rule out a hypothyroidism as well. So I was like, oh, like the owner was quite committed. So I took bloods for everything and TSH and all of that. A free T4. When I take him to the back, so this is what makes me feel so horrible. I took him to the back to take the bloods. We took the bloods. When we finished taking the bloods, he regurgitated. Like it was clear regurgitation. Blah. And he brought up all the treats that we had given him in consult. And I was like, okay, so he is regurgitating. He is not actually vomiting. And then I go back to the consult room and I said to the owner, look, he actually did a regurgitation episode. Are you sure that at home what he did the other day was a vomit? And then I explained to the owner and she's like, oh, I'm not too sure, blah, blah, blah. But the dog was doing so well. I was like, okay, look, let's wait for the bloods, feed him from a hide, feed him, try different consistencies to see if regurgitation doesn't happen. We got the bloods back, guys. Everything absolutely normal, super normal. Like no hypothyroidism, rule it out. Everything normal in the bloods, not a single abnormality. He presents 10 days later to the vet because he has gone off his food completely, and I think that I don't remember if it was a weekend or something, but he actually went to NEPS and was referred to internal medicine, and he ended up having metastatic hemangiosarcoma originating in the right atrium. So this dog, and I have the records here, so let me show you. Yeah, so let me just show you here. So on the records here, so Dr. David had a look at him. Yeah, so they were writing the records here, and then they wrote here what I wrote, like, oh, regurgitation, more recently not vomiting as much, will regurgitate, specifically something called food from the fridge. But anyway, he did an echo, and then they noticed like an enlargement in one of the walls of the heart, and then it was consistent with a mass, and then they did cytology and aspirates, and it came back with that, and then they did a CT scan and all of this, and he ended up having this horrendous problem. And then when I said, and then he comes back to the vet for actually euthanasia, and I was like, if I would have taken a radiograph of this dog on the day he presented, I would have probably, because he also had metastasis in lungs. So I was like, I should have done more when I saw the regurgitation episode, right? What do you think about that?
Those two
I mean,
Jeff.
Okay.
he came back like,
Which is
Right. Okay, thanks.
You're welcome.
I mean, at the end of the day, things didn't get better and the dog represented and the diagnosis was done. So I don't know if you need to feel terrible about not doing imaging on the first visit at all. Like, this is a really extreme case. Like, things would have progressed anyway. It's not like intervention with treatment would have saved the day for a heart-based hemangiosarc with pulmonary mets, like systemic hemangiosarcoma. I think you can't do everything. You're more risk of getting someone complain that you did too much on the first visit for a one-off regurg. I mean, the weight loss is concerning, 500 grams for a dog of that size. But to me, I would have just thought it was like a footprint of chronic enteropathy, that they hadn't really told the whole truth, or they'd kind of minimized it a little bit. I wouldn't have done imaging, I don't think, on the first.
I wouldn't have either.
Two regurges. I would have said, come back if it doesn't get better, which they did come back. So I wouldn't beat myself up about this.
I'm not sure that the regurgitation has anything to do with what was going on in this dog. I think it was just like,
I can't link it. Like,
because the tumor size probably wasn't that big.
they'd be tiny. Hemangiosarcomas are tiny.
Like, I mean, have we got it in front of us? Like the mass is 2 centimeters by 3 centimeters, so they're not going to be causing like regurg from a obstruction perspective.
If you look at it, that mass is in the interventricular septum. It's inside the heart. There's no way it was putting pressure on that.
Yeah, you wouldn't see it on an X-ray.
No.
Because of the metastasis, do you think like the esophagus also, there is an so the esophagus goes inside the thoracic cavity. If there is metastasis and inflammation around that area, could that inflame the esophagus and perhaps they can develop regurgitation?
If you had like a big carcinoma, like pulmonary carcinoma or sarcoma or something like that, that was pushing on the esophagus for sure. But hemangiosarcomas, particularly intracardiac ones like this, their mets are less than 10 millimeters. Like, they just shower these tiny little cells throughout the whole body, and the dogs die of bleeding. They don't die of,
I mean, that's
compression or mass
the
lesion.
regurg be like a vasovagal issue because of some hemostatic mechanism from the heart.
Don't know. I would say the regurg is probably because it ate sharp treats.
Right. Yeah.
Yeah.
Because of
Like, you know, that like this is the trouble, you know, dogs go off their food for other reasons and owners start feeding them weird stuff that causes gastrointestinal signs. Like
Yeah.
there's absolutely nothing I would have done differently here. Like the owners pursued the right course of action at the right time. And I don't want to downplay, like we sort of say, oh, you know, if I'd done all this testing first, I would have like seen this earlier. So then you end up doing like sedation, not light sedation, to do a series of good quality radiographs of every dog that comes in with 1 or 2 regurgitations. And your complication rate associated with that sedation, hospitalization, not to mention anxiety and financial strain on the owners, your complication rate outweighs the like outcomes of the testing that you're doing. So you might catch 1 in 100 dogs where that was a good idea to do the radiographs, but you've actually caused a whole heap of financial and emotional stress on the owner and the dog.
Yeah, can I just share to that point? Years ago, when I was working in London, I had a flat-coated retriever that I ordered an ultrasound for chronic or like enteropathy picture, and we I think did under very light sedation. Can't exactly remember, but the dog just collapsed, had cardiac arrest just as we were recovering it from the ultrasound, and then it had a heart-based tumor, and then we did CPR, and then it died after transfer later that day. Yeah, that was so. If you had have done like, to me, it was better to find out the way that the clients did than to find out that you did imaging early and find it, and then the dog died from the sedation unexpectedly because you didn't have it on your radar that it had. I mean, it shouldn't scare people away from doing imaging, obviously, but yeah, I wouldn't. I think
But it
done
also,
great case.
Yeah, I think that you managed that case perfectly.
I just think
and
that
so did the owners.
Yeah, I just think that is perhaps the lack of critical thinking on an older pet that has mild weight loss, and you actually evidence regurgitation, right? You should think outside the box a little. I don't know.
I mean, the weight loss, how old was the dog?
Like 10?
A 10-year-old cavoodle, did you say?
That's a young dog.
It was a, what's the breed? It was a white Japanese Spitz cross cavoodle.
Okay. I mean, I wouldn't be getting alarm bells from that. There's like a heart hemangiosarc. Maybe if it was a Bichon Frise, maybe with some of the recent cases I've had, but that's not that. I mean, the weight loss that you would want to demonstrate that it's not under nutrition and that the dog starts putting on weight.
You did bloods.
You're getting
Yeah.
And but if a dog's lost like that much body weight and the bloods are normal, unfortunately, I'd be thinking cancer as a differential.
Yeah. Yeah, I think you managed that completely fine.
Just going back to the vascular ring anomaly, I did X-rays for follow-up X-rays for a dog that it was actually that one that I asked you about, whether stent surgery was like worth doing versus it being more damage.
Yes.
But when you mentioned like the pinch in the trachea, because I've just put it, it's like a multi Shih Tzu that's always had like cough when excited and everything, and I'm just like, it's just DAD. But actually now I'm going to go back. I might show you the X-rays.
Do share them.
2 years in a row, there's like this weird kind of ring thing, like this weird thing at the heart base in the trachea. I'm like, ooh. And you know, given like the likelihood of like shunt, etc., in that breed, I'm just thinking like they're kind of the breed that's going to throw an embryological vascular anomaly.
Okay. Interesting. Go back. Okay, so I think we should probably move on to vomiting. The main thing I want everybody to get out of the kind of regurgitation discussion is there are like a number of different causes of esophageal dysfunction we see, and I think if you have in your head mechanical versus functional obstruction, we haven't talked much about functional obstructions, but essentially neurogenic, myogenic, or junctional, the main ones. but then also have inflammation on your radar because that will reduce muscle tone. And when you're doing your radiographs, it has to be conscious because sedation will cause dilation of the esophagus, and always screen for aspiration pneumonia because regurgitating dogs very commonly have a degree of aspiration pneumonia, which will complicate your management. Okay, let's talk about vomiting. Can anybody tell me? Okay, I'm just going to throw questions at you as if this was a medicine membership exam. Okay, can somebody tell me the mechanism of action of meropitant?
It's like substance P chemo trigger receptor zone.
Yeah, it's a neurokinin 1 receptor
NK1.
antagonist.
Excellent.
Antagonizes
Yes.
substance P.
Yep. And where do we see neurokinin 1 receptors?
In the brain and
Everywhere. Is it like everywhere?
It's everywhere. Yeah. So neurokinin 1 is like a fairly new kind of discovery. And the more we look into it, the more we're like, oh, and it does this, oh, and it does this, oh, and it does this. So we're using meropitant for like chronic rhinitis dogs, for chronic coughing, and like there's receptors everywhere. So I think the point is that you're probably not going to get asked that in an exam because we don't understand it well enough to be able to say you're wrong or right kind of thing. But as far as the areas of the vomiting kind of pathway that it works in, the CRTZ, what does that stand for?
receptor trigger zone.
Excellent. And we also see them in like this little section that's right next to the emetic center. I'm actually going to share my screen and show you a picky. Okay, I know you can see my whole screen, so apologies. Can you see that?
Yeah.
Okay, so this is straight out of Edinger, which is actually then borrowed from the canine and feline gastroenterology text. I don't know why that's there, that's annoying. But essentially there's a lot of different pathways by which vomiting can be induced in dogs and cats. The key part to vomiting is the emetic center, which sits in the brain. There's a little tiny nucleus right next to the emetic center, and like literally right next to it, called the nucleus tractus solitarius or something like that. Let's just mumble that bit. NTS, which is where these neurokinin 1 receptors sit, and dampening down stimulation of this nucleus also dampens down stimulation of the emetic center. So emetic center and NTS are two parts of the central vomiting center. That CRTZ, what sort of stimuli would trigger the CRTZ? Like chemoreceptor trigger zone. Chemoreceptor is the hint.
So drugs like chemo drugs
Good.
would do it, obviously.
Good. Excellent. Yeah. So when we sort of use like medicine-y words, the chemoreceptor trigger zone causes vomiting from humoral inputs. So from kind of chemicals and circulating stuff like azotemia, like ammonia, stuff like that, will trigger the chemoreceptor trigger zone, which will then trigger the emetic center to cause vomiting. So if I said, what is the mechanism of action of ondansetron? What would you tell me?
It's inhibits like some serotonin thing.
Yes, good, excellent. What is the
5-HT3 it is, I think.
5-HT3.
Yes, good. So it's up here, right? And locally right down here in the gastrointestinal tract. So if we sort of say we know ondansetron's indicated in chemo dogs or patients, like that's what it was kind of designed for, it's going to be really good at blocking those humoral triggers of, yeah, exactly. So it's probably going to be quite effective in our renal patients, liver patients, and others with like extra gastrointestinal causes of vomiting. So the other inputs on the emetic center are not chemoreceptor triggers or not humoral, they're neurogenic, so mostly vagally mediated. And they mostly come from either cerebral cortex, the oculovestibular system, or the gastrointestinal tract. And they will, in dogs, the vestibular system triggers the CRTZ, which triggers the emetic center. In cats, the oculovestibular system triggers the emetic center directly. So that anti-nausea meds are maybe going to be a little bit different. If it's a vestibular cause of nausea in dogs and cats. Okay, what is the mechanism of action of metamide?
Does it antagonize alpha-2 receptors? And
It's not alpha-2 actually.
sorry, no, it's something else.
I
Is it a
studied
histamine
Isn't it also?
receptor? Is it a H1 agonist?
It acts on 5-HT3 and also stimulates as an antagonist and stimulates 5-HT4 receptors, which gives it a prokinetic effect too.
Good.
So yeah.
Can't
Yeah,
remember. Oh, it increases noradrenaline in the brain.
Does it?
Oh
It
no,
also-
sorry, is it something
It's
else?
a dopamine
right, it might
antagonist
do.
as well.
Oh,
Yes,
dopamine
thank
antagonist,
you,
yeah.
thank you. Yeah, so that's the main mechanism of action as an anti-nausea medication for metoclopramide. And then we have the added benefit if nausea is being caused by gastric stretch or ileus, we have the added benefit of the prokinesis, decreasing that stretch and the actual trigger of nausea at a level of the stomach.
Is that motilin receptor related?
Can't remember. Sorry. That's your homework now. Sorry, Matt.
Okay.
Okay, so let's go through a couple of cases because we're coming up to membership exams and vomiting, regurgitation are classic case examples. So I want to talk to you about this dog who's come in with vomiting huge volumes of just fluid. When you question the owner, there is a combination of vomiting and regurgitation reported. And you do bloods and all of the biochemistry is normal aside from these electrolytes here. What's your first impression of these electrolytes?
Severe derangement, hyponatremic, hypochloremic, hypokalemic. So I'm thinking, do we have blood gas?
It's alkalemic.
Alkalemic.
Yeah.
Yeah, okay. So then, like the first thing to rule out would be foreign body obstruction.
Yes. Why?
Metabolic alkalosis is not hypochloremic, hyponatremic. Metabolic alkalosis. Proximal GI obstruction is a big cause.
Proximal GI obstruction. Excellent.
The
So
other
when
cause
I
also
say-
is hypoadrenocorticism for that.
Yes, except this is
The sodium to potassium ratio.
Sodium's not, yeah. In this case,
Yes.
maybe not. Yes, not in this case.
Yes. So this was actually, when I told you the biochem was normal, this dog actually had a raging azotemia and I was like, oh, could it be azoteme? Could it be Addison's? But the hint, proximal GI obstructions, you get all of the electrolytes go down. So sodium, potassium, and chloride, as opposed to Addison's, where the potassium is usually normal or high in a crisis.
Mm.
So when all three of those electrolytes are down, I would be looking in the proximal GI tract for an obstruction. And with that historical combination of regurgitation and vomiting, it's probably something that's causing a lot of stasis or ileus in the stomach.
Yeah.
So this is a 13-year-old Jack Russell, which should have known better. I should have told you. Oh, no, that's not her. But I'll show you this one anyway. So this is a cat who presented with vomiting. And ultrasounds are awful to interpret as a still, but can you see this?
Yeah.
So here is a fairly normal looking piece of intestine. We've got gas in the lumen here, we've got a black mucosa, a white submucosa, a black muscularis layer. Can anyone give me a little comment on what's going on in this loop? What looks different in this loop from this loop?
The muscularis layer looks particularly enlarged.
Yeah, profoundly thickened focally in the muscularis layer. But what I always note is that there's retention of normal layering. So we can still actually see that submucosa and mucosal layer there, which makes neoplasia a little bit less likely, but still, or low grade if it's going to be neoplastic. So then if we look at a couple of other images of this cat, this is a longitudinal section of that same stretch of intestine. Again, you can see mucosa, submucosa, muscularis layer, the layering is retained there. And this is a cat with acute onset vomiting, I should say. On ultrasound, this stretch of intestine was around about 6 centimeters long, focally abnormal and kind of in the middle of the intestine. So distal duodenum, jejunum kind of area. So it was sent to surgery and it actually came back as a focal neutrophilic inflammatory response.
Did you say focal neutrophilic? Neutrophilic? Focal?
Neutrophilic.
How?
Yes. How, indeed. So the two main differentials for that are an enteroadhesive or invasive organism, infectious cause. If it's neutrophilic, be suspicious of infection, or a foreign body that was lodged there and has since moved through. So if you had a fur ball, 5 centimeter long fur ball that was lodged in that spot, and then you hydrated the cat for 24 hours before the ultrasound was available, quite possible that that's what was happening. Now, this cat had a little bit of peritonitis around it, so surgery was indicated anyway. And because of the other differential being epitheliotrophic or low-grade neoplasia, surgery was recommended. But one of the sort of gastrointestinal causes of vomiting.
Can I go on a bit of a tangent with that case?
Yes.
So if you do surgery and you resect that bit, and if it's so focal and if it's neutrophilic, is there any need for microbiosis?
I would say no, apart from the standard perioperative gastrointestinal kind of Kefsol that the surgeons use.
Yeah.
Unless clinical signs didn't resolve with symptomatic management.
Would you need to check distal to there to make sure that the foreign body hadn't moved but was still present?
Yeah, absolutely. So anytime we're doing gastrointestinal surgery, I always ask the surgeons, I just say run the bowel. So I want them to go top to bottom and just make sure that whatever we're kind of looking for is localized, because ultrasound is not a good test for gastrointestinal tract. It's really easy to miss stuff. So if there's a focal abnormality, I always say run the bowel, make sure that A, nothing's moved through, or B, this is not actually multifocal and I've missed it. Okay, 2-year-old female neutered cavoodle who presented with a 48-hour history of vomiting. Someone describe these radiographs to me.
2 populations of bowel.
Next radiograph.
Do we want the next radiograph, did you say?
Do you want the next one? Yeah.
Yeah.
Sure.
Yeah.
So you got increased liminal space above a vertebral body. I mean,
what?
as in like the
I see what you
liminal
mean. Yeah.
space is thicker than the vertebral body.
Yeah. So we've got evidence of obstruction.
And the suspicious shape in the caudal abdomen.
Like here?
Yeah.
Yeah. Excellent. So what are your recommendations?
Space occupying lesion.
2-year-old dog.
Oh, 2-year-old dog. Yeah, no problem.
Yeah, if that's a small intestine, it's definitely obstructed.
And is there like graveling sign in the stomach?
I don't know. I think there's foreign material in the stomach.
That's
and I
just
think
foreign
it's just,
material there.
yeah.
Yeah.
It's not
But not the
gravelly.
bottom.
Yeah.
Yeah.
Is anyone seeing any evidence of fluid in the abdomen?
But
Yes, there's lack of serosal detail.
A little
Crane.
bit back
Yeah,
here, isn't it?
caudal to the liver.
It's difficult. This is a very lean dog. I feel like I can see a liver margin there, but it's pretty burnt out down this skinny end of the dog relative to this end. Around here, I think we've lost a little bit of detail around here, but I can't see a raging peritonitis. What are your recommendations to this patient?
Abdominal
It's
ultrasound.
Yeah. Are you just saying that because I do ultrasound?
I mean, if the owners can afford, it's always better to go in and actually collect more evidence. But
Yeah.
if the
Yeah.
ultrasound was not available, looking at
Yeah.
this, I think cut would also be a right thing
Yeah.
to do.
Yeah.
So
Well, I
if
mean,
you-
what would you would have done bloods by now as well to know maybe what it's like lactate and its CBC were doing, but I'd be looking at XLAP.
Good. So what if I said to you, oh, I can get there tomorrow, but not today?
Oh,
Uh,
not a good idea. Then yeah,
Cut.
X-lab, I suppose.
would-
Cut. Yeah.
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 Last year,
And-
I have had 3 cases in emergency, where I did bloods completely normal, like nothing. I did X-rays and I was like sitting on the fence. So I got an opinion of the surgeon and they didn't want to come in because they said nothing. 3 cases, definite, like later on had foreign body. So now I've learned my lesson to not just base it on normal X-rays or even normal bloods, because that can happen.
Yeah. And whilst like surgery is such a big deal financially and things, but missing a foreign body is also a big deal, like a bigger deal financially and health-wise for the pet.
Yeah.
Dogs recover so well from an X-lab, and cats, I should say. But I don't know if you can see this very well on your screens, but you can actually see the corn kernels. It's so pleasing.
Oh,
So this
Not on
is
the screen, but yes, now that you
Yeah.
point it out, you can
did
see
you say
that.
corn cob?
corn kernel. Yeah, you can see like the little kernels there.
I mean, I haven't seen one for years, but you can could you not feel? I mean, the other thing is palpation.
Yes, I just
skinny
we
dog.
should skinny dog and give them some sedation. Like make
Yeah.
sure you're giving yourself a really good chance to have a good feel, because and then use that as your pre-med to go to surgery, because often once they're relaxed, you can really have a good feel in there and go, yeah, there's something.
Yeah, I reckon corn kernels are the easiest to feel and tell that it's a corn kernel. I mean, I know it's like
That's true.
things
Yeah.
happen commonly, but like
Now this is the last case I want to cover, and I know I'm going to have to run bang on 9 o'clock, but this is a 4-year-old dog who presented with regurgitation and gagging over the course of 3 days. What do you think of this X-ray?
The dilation of the esophagus.
I can't see any
I
actually.
can't, I
I
think
think
I'm
it's-
calling this normal.
I'm calling this normal too.
Yeah. Okay.
Next rad. No gastric distension there. Everything is in order. Happy?
Mm-hmm. That's okay.
Change the factors just to make sure. There's a little bit of gas there, isn't there? Is that acceptable?
Where here? This? Like in the stomach, you mean?
Yeah. Tiny bit of esophageal gas.
I guess it depends. If the pet was sedated for X-rays, maybe it's
Mm.
normal.
Agree. Yeah. And there's actually allowed to be a tiny little bit of gas here, because the dogs are swallowing gas all the time, and you might catch it on the way past. Yeah. Particularly when they're being restrained. But yes, just a tiny sip of gas is allowed. And if they're sedated, it's definitely, you couldn't make a call on megaesophagus or anything. But I don't think there's megaesophagus here. The VD was normal, so I don't have it. Does anybody have any, so this is a dog with regurgitation, retching, like really kind of esophageally kind of signs.
What's the breed? What's a signalment?
Oh, it's a 4-year-old mixed breed. Sorry, female neutered mixed breed. Don't know. It's not a breed specific problem. But if you were in an exam and you had that history and these radiographs, is there any other views that you would like to see?
BD.
VD is normal. VD of the chest is normal.
Would you want to do a, like, you know, the compression, like put the spoon to see for dynamic sliding hernia or something?
Oh yeah,
Like,
that's a good
what
idea.
is that view called?
Good idea. So I would do like a specific study looking for evidence of sliding hiatal hernia. So there's a couple of techniques where you do that. So applying abdominal pressure, which forces the stomach up into the thorax. Another thing that sometimes we do is have them intubated and cover the end of the tube to create that negative pressure in the thorax. And then take a radiograph as they're kind of trying to take a breath in against negative pressure.
Would you want to include this larynx or not necessary?
Yes, we definitely, if you're looking for an esophageal foreign body, always do a cervical neck. What's that?
Not normal? Or is it
Not
normal?
normal. No.
So is that a bone?
That's a bone in the proximal esophagus. Yeah. So you can't rule out, like when we're talking about vomiting regurgitation, the gastrointestinal tract goes from where you can't see it here all the way to the anus. Like make sure you're imaging all of it, because we do ultrasounds of so many dogs with vomiting that actually have esophageal foreign bodies, and the gastrointestinal tracts aren't normal. Like they've got gastroenteritis because there's nothing moving through there. So you do an ultrasound, call it gastroenteritis, and everyone thinks they've got their answer, but actually there's something really nasty brewing in the thorax or cervical esophagus. So that's just my little lesson. With everybody's missed an esophageal foreign body. But yes, make sure you're doing radiographs right up to the head. All right, I better run away.
Thank you, Anna.
No worries.
Thank you so much.
No worries. I can't remember what. Oh, melena, hematochezia, and constipation next time. And we'll try and make it really case-based. And then after the next one, I think we'll probably be up to doing practice exams. Excellent.
Cool.
Thank you.
Thank you.
All right. See you guys.
Bye, everyone.